Hi, I'm Suneet Mittal from Heart Rhythm TV, and I'm joined by Professor John Kalman from Melbourne, Australia today. And we are at the European Heart Rhythm Society meeting in Barcelona. Welcome, John.
Thanks so much, Suneet. It's a pleasure to be here.
So, John presented a fantastic study yesterday looking at timing of catheter ablation in patients with atrial fibrillation. And John, for our colleagues who weren't able to be here or may not have had a chance to read the publication in the European Heart Journal, thought what a great opportunity to sit down with you to go over a little bit about what was the genesis of the study and maybe explain a little bit about the study design.
So the study, I guess we had the idea for the study. We looked at emerging data, really pushing the idea that maybe catheter ablation needs not only to be first line, but that it's really important to ablate early, because if you ablate later, outcomes are worse. And there's emerging data with the diagnosis to ablation time suggesting really large impact on ablation arrhythmia outcomes. And, this, I guess, challenges the traditional concept of treating some patients with antiarrhythmic medication, and which is common certainly in our geography still for patients to be managed in discussion with the physician with the antiarrhythmic. So this trial was really asking the question, do you have a window period where it's okay still to treat patients with antiarrhythmic medication, or really do you need to, in the current era, take patients who are diagnosed and take them very rapidly to an ablation procedure?
So, John, could you just summarize a little bit about the design of the study, what kinds of patients were included and what the two strategies were?
So the patients, we would describe this, at least in our geography, as a real-world study. That they were patients referred for management to a tertiary centre, an advanced AF centre, and with the understanding that there may be ablation as an intervention or medical therapy. But we discussed that with patients. Those who really wanted to go to early ablation were those patients who were excluded from the trial, and those who were prepared to undertake medical therapy were then randomized either to ablation within a month or to a period of medical therapy over 12 months and then offered an ablation, with the understanding that most of them would most likely take the option of the 12-month ablation. And during that 12-month period, we managed them very actively in terms of maintenance of sinus rhythm with up-titration of antiarrhythmic doses, changing to alternate antiarrhythmics if the particular one they were on was not effective, considering cardioversion. So we didn't let patients languish in persistent atrial fibrillation, and we excluded any patients with long-lasting persistent atrial.
Yeah. And briefly, John, what were the findings of the study?
So the findings of the study were that if we looked at 12 months, that is 12 months after ablation in the early group and 12 months of medical therapy in the medical group, we had a clearly higher AF burden, around 16% in the medical group, 0% in the median burden in the ablation group. More symptomatic in the medical group, as many studies have shown, higher antiarrhythmic drug use, of course, which had dropped away quite dramatically in the ablation group. But when we then ablated that medical group, and the majority of patients underwent ablation, although there was a small number, 5 of the 6 patients who didn't undergo ablation elected not to because they were doing well on medical therapy, very well controlled. But for the rest of those patients, when we looked again 12 months after their ablation, there was no difference at all between their arrhythmia burden, their symptom outcomes, and their overall arrhythmia-related time to AF recurrence outcomes compared with the early group. And we just felt that this was reassuring data that says to us, look, you do have a window period to treat patients medically, to have that conversation with patients, whether they want an early ablation, whether they prefer to trial a period of medication and see how they go, before making a decision to progress to ablation. So the pressure comes off us a little bit in terms of needing to recommend an early or immediate ablation.
Yeah, and conversely, I think that we shouldn't pressure patients into pursuing an early ablation if they're not ready for it. I think it really is another area where shared decision-making is very important. Another opportunity to discuss the pros and cons, knowing that fortunately we're not going to be adversely impacting the outcomes of what we're doing for these patients.
Yeah, that's exactly how we would see it. That's really beautifully put. Thank you.
Beautiful. Well, John, thanks very much for spending a few minutes. I think everyone's going to love reading this study, and it really gives us, further insight. How do we care for our patients with atrial fibrillation?
Thank you so much.